rosuvastatin 40 milligrams and ezetimibe and all of these things, thank you very much, but he's actually signed a waiver and lets me tell his story. He was continuing to have heart attacks, so he is on one of these really cool PCSK9 inhibitors, which is essentially an injection for your cholesterol. And I saw him, he lives in Arizona, he comes in, and he says, yeah, he says, I heard about those aspirin guidelines, you'd be proud of me, I'm reading up on all this stuff, so I stopped my aspirin because I heard that we don't need it anymore. And I'm like, oh man, I'm like, yeah. I said, those people that they found, they live in Europe, and they had like no risk factors. I don't know where they found people over 65 with no risk factors, but they did. So anyhow, it's appropriate for some, but in an urban society where we have very few people, bleeding to death these days, that the aspirin for high-risk patients in particular is very valuable. So that's where the guidelines can actually not be as helpful because it can sometimes stem a lot of confusion.
And I just want to back up Margo on that. In our work in our first University of Best Practices funded by NIH in San Diego, one of the main things we did was bundled medication therapy management for diabetics and cardiovascular patients to give them aspirin, Lipitor, and lisinopril. And we dropped heart attacks very quickly by 22%. AMI hospitalizations, 3,826 fewer heart attacks associated than were anticipated with that bundle. It wasn't the only thing we did. We also added the pharmacist to the care team, etc. But when you look at the broad benefit versus risk, the small amount of bleeds, I don't think outweighs it, and I think we're going down a dangerous path.
Yeah, I think the jury's still out on it. In conjunction, there was a trial that was presented about 1.5 years ago at the American College of Cardiology. It actually didn't focus on the United States. It was multi-studied from Africa up through Europe and Asia, and it was a concept of a polypill, same thing, statin, ACE, and an aspirin. And they also saw large reductions. So I think that we can feel fairly confident, and in particular for those patients that do have multiple risk factors, that there's definitely a role for them. So I'm just putting all of this out here right now, and there's one good piece of information on each one of these puzzle pieces that is important, and we don't have time to cover everything today. But I'm plucking out some of the things that I feel are a little more nuanced. So we have a clinic that we use, and I think that everybody should have this app. It's fantastic. It is was designed by the American College of Cardiology. I had my hand in the statin guidelines and in helping to implement some of this, and just a really cool algorithm that we use, and you just plug these numbers in while the patient's sitting in front of you, or if you're at Christmas or Hanukkah or any other family occasion where somebody wants to ask you a health-related question, you can tell them if they're at low, moderate, or high risk right then and there, if they happen to have a good idea what their blood pressure and cholesterol numbers are. Now, one of the cool things about the new prevention and lipid guidelines this year is that we highlighted risk-enhancing factors. And just to remind everyone, ASCVD is atherosclerotic cardiovascular disease. It's the new kind of coined term for cardiovascular disease. It's a little more all-encompassing when we talk about it. So there's a few things in particular that they finally highlighted that is in particular for women. Women who go into premature menopause, women, as I said, post-menopause, when we start to look at these adverse pregnancy outcomes that I mentioned, when we start to think about people who have persistently elevated high bad cholesterol, which is the LDL, which is the lousy bad one, these add to your risk. And so I'm going to show you within a few algorithms how we can utilize that. So we're gonna talk primary prevention. Primary prevention is somebody who's never had a major event. They have not had a stroke, they have not had a heart attack, they have not had an acute coronary syndrome. And so when we think about people, the first thing that we do is we talk about lifestyle. We start that off with children. We go into elementary schools and we start to teach them about, the healthy 7 things, and we hope that they share it with their parents, and then it moves on up. So once we start to do that, pretty much everybody should be screened before you go away to college for a genetic cholesterol disorder called familial hyperlipidemia. I'll call it FH. It is an epidemic. It runs in certain family trees. We have isolated 3 gene mutations currently. We have beautiful treatment on how to treat it. The hard part is catching people before it's too late. And for some people who are homozygous, too late could be 20 years old. So if you know somebody, or if you yourself have had somebody die, or several family members die very young, and it could have sounded sudden, and it could have sounded like it was something else, it could have been sudden death from a blockage. So we're actively trying to screen people. Once you start to move across the age cascade, we start to estimate lifetime risk at that point. And then for those individuals who are 40 to 75 years of age and who have diabetes, and those, the LDL over 190, you almost don't even need to do genetic testing these days. Ladies and gentlemen, you cannot eat enough McDonald's to get your LDL up to 190. It's kind of hard to do unless you're predisposed to it. So you see the green boxes because that is go ahead and offer them treatment and give them compelling data to show them why treatment is good for them. You can see it has a class 1A recommendation. The yellow box shows a 2A recommendation, which is where the benefits outweigh the risk. And so really it takes a great clinician, patient discussion, I think, in more of those areas. So once we start to look at people and we start to figure out, wow, what box do I fall into? Number one, if you notice, we've got lots of green finally in cardiology. We actually don't have to rely on expert opinion anymore, and in fact, it doesn't really matter what I say or anybody else who will claim to be an expert. We have excellent evidence-based medicine data that is backed, and we can really show people that the benefit does outweigh the risk. So if you're labeled low risk, then you can pat yourself on the back, keep up your great lifestyle, and reassess yourself in 3 to 5 years. If you're borderline risk, you want to start to have that risk discussion, and you want to start looking for those risk enhancers I was telling you about, right? So medical students, you always want to get an OBGYN pregnancy history on all of your patients all the time, all of your female patients. Very important because you can look for those things. And they're tattletales. I mean, there's a lot of college kids, for example, that are in athletics, or they're up all night, they're doing their rounds, and for women, they stop having their menses. And we're starting to think that might be linked to something not good. And so we actually have an NIH study looking at that. Once you start to go over 7.5% risk and you're still under 20% risk, I'm at that point having an active discussion on, wow, let's talk about, some preventive vitamins for you and some statin therapy and what that might be. And then if you're over an LDL, if your LDL needs to be reduced by 50% because you have a gene mutation, or you're otherwise labeled high risk, I'm kind of on my hands and knees begging them to take the medication. Now, when we start to look at these middle areas, it's like, gosh, how do you know about risk between borderline risk and intermediate risk? It starts to sound kind of vague. Well, luckily, we have some newer tools, and they're not really newer, but the data has just become so robust that we feel quite confident if you're kind of falling down the middle of the road, or even if your provider's telling you that you need to take a statin, but you may have different reservations. Maybe your Aunt Betty and your Uncle Harry and your Aunt Donna couldn't tolerate a atorvastatin, rosuvastatin, pravastatin, pitavastatin, and you're kind of worried that you're going to be one of those people. A coronary calcium score, which is essentially a chest x-ray of your coronary arteries. Now very low millisieverts, very easy to do. Really wish it was covered more by payers. We can really see the power of zero. We can really pat you on the back and rest assured and really start to focus more on the lifestyle and the nutrition and the exercise piece of things, and give people a little bit of a breather while we're getting always more data and learning more. If it's anything other than zero, you really want to strongly consider medication therapy at that point. And the number one thing to do is a statin.
And may I just ask you, with women's and men's coronary
Yes.
Scores, is there a different level? Do you see anything different between men and women and calcium scores?
We do. There's actually some gender differences, so that's a great question. So, for example, what if you're a 40-year-old woman and you've got a really strong family history of heart disease and your LDL's coming out 159 and you're not over 160, you're not 190, and we're kind of looking at you and you're 40, and age is the number one predictor for the risk calculator being the most effective. So you could look at those risk enhancers, or you could think about going for a coronary calcium score, but here's the problem, and I'm going to go over a little bit of coronary physiology towards the end. Women don't tend to calcify their plaque as early as men do. So on occasion, we can falsely reassure somebody who's under 40, and maybe even somebody in their early to mid-40s. By the time they're 50 and over, they're starting to, we should start to see something, and the data is quite robust that we're probably not missing really much at that point. But for younger women in particular, the coronary, we just don't calcify. We have seen autopsies with, women who had zero calcium, and it was just all soft plaque with some vasospasm and a blood clot. So coronary physiology is complicated. But with that being said, the epidemiology behind it suggests that the coronary calcium score may be of benefit. But if the medication is free and you can take it and it's really easy and you're kind of even scratching your head, I'm sort of like, you need to argue to me why you shouldn't be on it. Now, that's a very different clinical scenario from this person who would be considered a very high-risk patient. So a very high-risk ASCVD patient is somebody who's had 2 or more of these major ASCVD events. So that's an acute coronary syndrome within 12 months, within a year, a history of a heart attack, a history of an ischemic stroke, or they have symptomatic peripheral artery disease with claudication. Or you can have one of those major events and then you have more than one of these high-risk conditions. So you're diabetic and you're hypertensive, or you're smoking and your kidney function is starting to decline. All of these things make you a higher risk person.
I didn't see AFib up there. Obviously AFib gives you stroke risk, but does it also make you a greater risk for MI, or is it unrelated to it?
That's a great question. Clots throw. So, typically speaking, they're more stroke related because it's going AFib, it comes off the aorta and goes up to
But the cause of the AFib isn't necessarily coronary artery disease.
That's correct. Sometimes it's valvular diseases that cause the left and right atria to slightly enlarge. Typically people with AFib traditionally on an ultrasound of their heart or an echocardiogram will see some enlargement happening. Patients who have heart failure, cardiomyopathy related heart failures, of course, anything that's enlarging that can stretch those myocytes so that the signal is not coming from where it should be, it is. But yes, if the guidelines are, it's sort of an inference. Obesity is not on there either, but we know that obesity can lead to diabetes, that can lead to,
Okay.
yeah, great question. And I'm sure they haggled a lot over it when they were putting those guidelines together. When we start to think about prevention and we go, okay, well, you're not a really high-risk person, then the next thing we look at is age. Are you under 75 or are you over 75? Well, if you're under 75, we're gonna really be talking to you about starting a high-intensity statin, and there's only two, rosuvastatin and atorvastatin. So that's the right medication for the right patient. You've got plaque, you wanna make sure that you're on one of those two. I start to really think about, especially in Southern California, the discussion around frailty. When I start to talk to my patients who are over 75, I have some seniors in my practice that would run circles around me and run triathlons, and I laugh at them because they're like the new version of the Sex and the City. Their husbands are gone, they're single, they got money, they're having a blast. If they want to take a high-intensity statin and they can tolerate it, by all means, I'm prescribing it. So I do think there's a little bit of situation around it, but we do worry about polypharmacy. We consider it, we try and look at CYP pathways and the way that these drugs metabolize and try and be a little more selective maybe with the cholesterol-lowering medication that we recommend.
I just, with respect to this slide, we talk about primary prevention.
Correct. But they have ASCVD.
But they have ASCVD.
Correct.
And I think, that's been a little area of
Plaque, no heart
confusion.
attack or stroke.
Right, so they haven't had an event.
But they're high risk.
But they're high risk, so they.
So high risk, high intensity statin.
I think sometimes we get fixated on, primary versus secondary.
That's right.
We all know secondary needs.
That's right, but you can be walking a tightrope and still live in primary care land and primary prevention, which is why our primary care doctors and our OBGYNs really need to be equipped with this knowledge. They're our front lines. Now, when we start to think about secondary prevention, you just teed me up perfect. And they have plaque, they've had one of those events that I've mentioned. If they're not very high risk, but they've had a heart attack, then we start to look over here at the very high risk person, and we're really throwing the kitchen sink at them at this point. Essentially what I do in my clinical practice is I order a couple additional non-statin medications after I've got them on their highest tolerated, hopefully high intensity statin, and then I'm ordering a PCSK9, which will take me about a month typically to get to the patient, and ezetimibe, which also has some good robust data. I will say though, their data is in an older population. 70% of the patients in their study were male, and it took about 7 years for them to see a net benefit. So if I'm looking at a young female vasculopath, I am really going hard for that PCSK9 inhibitor. And you had mentioned LPA. The PCSK9 inhibitor right now is the only medication that really does a great job reducing LPAs by about 32% and up to 50 to 60% in some patients. So if they have that gene mutation, it's a lipid gene mutation, that is a great medication for them to use. Now, everybody always loves to talk about weight gain, and I'm sorry, and I hope this doesn't offend anyone, but it's a really old slide, and we all use it, and we laugh at it every time we put it up because it's true. Is menopause really to blame? Like, our women come in all the time, they're like, well, I gained 10 pounds because I'm in these darn hormones of mine. And in fact, when we look at the facts about weight gain, it's actually true, but unrelated. The average woman is gaining about 1 pound per year after the age of 40. Now, this discussion's gonna get a little depressing for the women over 40, so please don't, key my car or send me hate mail, but it has a silver lining at the end, I promise. So it actually coincides temporarily, but you're basically gaining the most amount of your fat before you actually hit into menopause, which is usually around 51, 52-ish. And that's due to these metabolic changes that occur with age. And this is where it gets depressing, so bear with me. We have a decline in our lean body mass, which reduces our metabolic rate, which then decreases our physical activity, which then decreases our lean body mass and decreases our energy expenditure when we try to exercise, and then we can't sleep, and then we have reduced physical activity and weight gain because of that, and then we get increases in abdominal and visceral fat, and then we all wonder why we're miserable. Well, so then they actually were able to validate all of that with a bioelectrical impedance analysis, which is kind of cool. And then this is where they were really able to document in the SWAN study that fat mass increased before menopause and actually leveled off. So it kind of, it surges and then it stays, which is good. Once it slows down, you can actually combat it with exercise. And high intensity interval training is really the way to go. If you're over 30, the way you exercised in college ain't gonna do it for you when you're over 30, in particular when you're over 40. So we call it HIT training, H-I-T training. So if you wanna learn more about it in detail, you can Google it and you can read all about it. But basically, you start off and you will do maybe some, walking, brisk walking if you can, and then for 15 seconds you try and do something fast. Might be jumping jacks at the beginning, might be a little wind sprint, might be some, but you're trying to get your heart rate up and you're trying to do it really fast for that 15 seconds. You'll do that for a week or two, and then you start to reduce the amount of slower time and increase the amount of the faster time. And it goes into 3 different phases. And so it's important because it really helps to jumpstart your metabolism. Now, a lot of people say to me, why can't walking give me the same benefit of when I'm in the pool? This is why. 5 minutes of a run generates the same benefits as a 15-minute walk. So for you busy people out there, start jogging. Start jogging. A 25-minute run is equivalent to a 105-minute walk. Do any of you have an extra 105 minutes? Probably not. And so we know that elevating our heart rate is a good thing. Now, just a few clinical pearls. 15 extra calories per day. That's like a stick of gum that's not sugar-free equals 2 pounds a year. 2 pounds a year for 5 years, you just gained 10 pounds. So we wonder why. And then the saddest part of all of this to me was, if you think about, major sources of calories, I love wine. I love my wine with my dinner. But of course it increases appetite, and then what happens? You eat more. And then it's also got calories. So you gotta combat it with the high intensity interval training and some nutrition. So there's lots of different diets out there, and everybody's always asking us, what do I do about this diet and that diet and gluten-free and vegan and no carbs and all of these things? Well, in a nutshell, we teach Mediterranean style nutrition. Now, I am married to a Greek Armenian. You might have noticed that Minissian doesn't really but my mother-in-law, who's going to be 98 in December, who is a hypertensive, diabetic, familial hyperlipidemic, is still going on her walks, and she lives on fish and vegetables and beautiful brown whole grains, and she eats everything Mediterranean and lived in Greece for the first 30 years of her life. For people who don't have a problem with alcohol, for women, you can have 1 alcoholic beverage with food. If you have it in a happy hour and you don't pair it with food, you don't get the same net benefit. Conversely, if you're an average size female and you have more than 1 glass of wine, it's also not good for you. It starts to actually give you negative connotations, even if you're having a paired 2 or 3 glasses with a meal. So for a smaller woman, 1 glass. If you're a taller, bigger woman, you may be able to do 2. It's really based off of BMI. Men unfortunately get away with up to 2 glasses of an alcoholic beverage, and it doesn't seem to matter. So back in the days when they were doing pathology reads, the pathologists, when they were looking at coronary arteries, they actually dipped the ruptured coronary vessel in alcohol, not the kind you drink, but alcohol, and that would stabilize the crystals. And that's when they started to get the idea that there was some type of a reaction that is taking place. And so we actually did a study between white wine and red wine and water, and we had cases of wine in our office. It was kind of funny. And we and others have concluded that the type of alcohol doesn't matter, but the quantity does. So if you're gonna have vodka or another type of a hard liquor, it's 2 fingers. If you're gonna have a glass of wine, it's 4 to 6 ounces, not the glass that your friend bought you for the holidays that's like the size of a horse bucket. Or a glass of beer that's 6 to 8 ounces. That's what we get. So it's all about proportion. If you notice on this pyramid, the base of this pyramid is 5 to 7 servings of fruits and vegetables with lots of nice brown things. Please don't be, unless you've been labeled celiac, please don't be afraid of carbs. They give you great fiber, and it all ends up kind of net balancing out, and you'll find that you'll be happier. I also like to try and teach people about calorie density. And once people start to have an idea about calorie density, they start to feel fuller, they feel more satisfied, they don't feel deprived, and they stick with it. I also pair it with some intermittent fasting for people who are trying to lose weight, and the Mediterranean fasting intermittently works pretty good. So like from 8 p.m. till, they can have a coffee in the morning but don't eat till lunch. They just tend to just sort of naturally start to shed calories. The Predimed study was kind of cool because we used to wonder if it was really the oils or the nuts, or what about the Mediterranean diet gives us. We have randomized clinical trial data, 3, showing reductions in heart attack, strokes, and death in the way you eat, which is pretty staggering compared to a regular traditional American diet. And it's actually these mono and polyunsaturated fats that are the good components to the Mediterranean diet. So it doesn't matter if you get that from raw unsalted nuts, or you're getting it from a teaspoon of olive oil.
A teaspoon.
It's all about the proportion. People go, oh, olive oil, it's so healthy, and nuts, they're so healthy, but remember I just told you about calorie density. And those things are nutritious, but I've seen lots of people get fat eating very healthfully. So it's all about the proportions. Now I get asked a lot about vitamins and supplements, and you might notice by now I'm a little bitter over the whole vitamin industry. So I'm leading the witness. True or false? Can you lower your risk of heart disease with vitamins and supplements? No, unfortunately not. They had a 20-year follow-up study looking at multivitamins and cardiovascular outcomes, and they had every type of outcome that they could possibly think of, 0, 0, 0. Might help your nails, it could help your hair, but chances are you have really expensive urine. And our United States economy spends $37 billion. There are very fancy, glossy buildings just down the street from Cedars-Sinai with vitamin companies on the side of them, with Rolls Royces parked out front. And at least half of the US population is taking them, so that's probably why. And women love vitamins, and they will take all kinds. And multiple studies have actually shown, besides no benefit, we've actually seen harm. So these lists of these vitamins here actually have hazard ratios going in the wrong direction. These are harmful things. Our Heart Institute director also linked vitamin C to higher rates of cancer. So it's great to get vitamin C from the orange, just eat the orange. And over-the-counter fish oil supplements, 2 servings of fish a week will give you about what the Costco capsule is giving you. Unfortunately, this is a study I was referring to. Now, we have a lot of women that are dealing with bone health and osteopenia and osteoporosis. What the heck do? They're always very confused.